So welcome to the latest instalment of the UQCCR seminar series, expertly put together by the wonderful Julie Wixie. And it's great to see so many people online. And I certainly think that this is going to be one of those fantastically insightful presentations that a lot of us will learn from. We have Nadeeka, who's presenting to us on clinical trials in dementia at UQCCR, and I hope that she's going to go into a little bit of detail about not just the clinical trials, but how she sort of got to this stage whereby she has these wonderful clinical trials and amazing clinical collaborations and scientific collaborations that she's been able to establish locally, nationally, and internationally. You would have seen from your calendar invitation that Nadeeka has a fantastic track record, and it's a very small summary which is provided there about that. But, you know, she's certainly done extraordinarily well in a very short period of time in her career. And, you know, we're very lucky to have her here at UQCCR. Not only is she an outstanding researcher, but she's a very complete contributor from a service perspective to UQCCR as well. And the leadership she provides at a UQCCR as well as a faculty level in terms of consumer and community engagement is just is fantastic. She's also the deputy chair of the UQCCR Research Committee by virtue of her outstanding capability that she has been able to demonstrate as a really productive and successful researcher. She's obviously won many awards as well, and that you can read all of that from the bio, which is included in the invitation. But I'd like to thank Nadeeka for presenting to us. We're very much looking forward to your presentation on clinical trials in dementia at UQCCR. And then after you, we're very lucky to have Dana presenting as well. So I'll introduce Dana at that time. But Nadeeka, are you happy to start us off?
Yeah, great. Thanks, Jason. And thanks, Julie, for organizing the seminar series. I'm just going to share my slides. Just bear with me for a minute. Can you all see my slides? Right?
Perfect. Perfect. Thank you.
Jason, thank you very much. So thanks for the introduction. I'm the head of Dementia and Neuro and Mental Health Research Unit at UQCCR, and my work is predominantly concentrated on dementia research, in particular clinical trials and clinical research at UQCCR. UQCCR is committed to work towards becoming a dementia-friendly center. In fact, we are the first center in Australia to make this formal commitment, and I'm really happy to announce it at the start of my talk. Apologies if I cough. I'm actually currently recovering from a respiratory infection. I like to acknowledge the traditional owners of this country and their custodianship of the land which we made today, and pay my respects to elders, past, present, and emerging. I also like to acknowledge the diversity and inclusion that UQ strives to create a culturally safe, welcoming, and inclusive workplace with strong community connection and partnerships. We are really fortunate to have an established consumer and community involvement group at UQCCR within our research unit. And I'd like to acknowledge members of the consumer and community involvement group who are present today to listen to this seminar as well. So thank you for being here. So in my today's talk, as UQCCR comes from various different themes, a variety of themes like cancer, infectious disease, fertility, as alongside the clinical neurosciences. I'd like to start my talk by introducing what is dementia and how important dementia is to us as researchers, as well as to the community. And then I'll provide you a brief overview of the clinical trials that are conducted within this space at UQCCR. And I'll focus on a specific trial in detail which we look at repurposing a drug to reduce the risk of dementia in Parkinson's disease, a drug called levetiracetam, which is used as an anti-epileptic drug. So within that, I'll give you an introduction of what is cognitive impairment and cognitive subtypes in Parkinson's disease. We will dig deep into the brain to understand more about the memory impairment in Parkinson's disease and its role of the hippocampus. And I'll provide a summary of the drug trial that's conducted at UQCCR. Alongside my talk, I'd like to highlight 4 key ingredients of successful research. That is consumer and community involvement, collaborations, partnerships, and early career research and leadership, which I will touch on as I walk through this talk today. So dementia is an umbrella term used to define many conditions, such as Alzheimer's disease, which is the most common forms of dementia. But also there are non-Alzheimer's dementias that are under study, such as frontotemporal dementia, vascular dementia, dementia with Lewy bodies, and particularly Parkinson's disease dementia. Dementia is used as a term to define problems like impairments in memory, thinking in ways you think, communication problems, as well as some of the behaviors in changes in behaviors like wandering behaviors, and some of the psychological symptoms like anxiety, depression that comes alongside. So it's a cocktail of a number of symptomatology that forms this word called dementia. And it's a neurodegenerative disease. Unfortunately, there's no cure for it, and it is progressive. Dementia is a highly significant condition to us Australians. Last week, in fact, the Australian Institute for Health and Welfare statistics, a report suggested that dementia is the leading cause of disease burden among Australians over 65 years age. Dementia just took over coronary heart disease. Dementia is in fact an age-related disease and a disorder, and it's expected to increase over time as we have an aging population. Dementia is also the second leading cause of deaths in Australia, and it's the leading cause of deaths in females. Currently, there are over 400,000 Australians that are diagnosed, and this figure is projected to increase by over 1 million by 2050. The cost of dementia is substantial to Australia, and annually we spend over $14 billion juggling with this chronic neurodegenerative disease. So it's a highly important condition for us to research. So within the space of dementia clinical trials, at our Dementia and Neuromental Health Research Unit, we focus projects ranging from dementia prevention, risk reduction, to dementia care. Our projects are conducted at health services, meaning hospitals, in the community, as well as aged care facilities. We have a very large team. In particular, we have members of our team predominantly consisted of early career researchers and PhD students. And our clinical trials coordinator is Tiffany O, who just is present here today, who does a tremendous amount of work driving our research unit. We have several themes, and our programs are consistent within the themes of Parkinson's disease, delirium and the connections with delirium and dementia, anxiety, which is a large theme where we look at diagnosis, neurobiology, and therapeutic interventions to reduce anxiety in people with Parkinson's disease, as well as people with dementia. Within our anxiety portfolio, we've been really successful in receiving grants, particularly with a large MRFF grant, where we managed to develop a platform to deliver and connect therapists with people living with dementia to deliver therapy or remotely deliver therapy or video conferencing. And the platform is called My Anxiety Care, which is just launched to recruit participants to trial the platform. Alongside, we've also got a new product that we've developed, which is a voice app, which helps with home-based assistance of practicing psychotherapeutic approaches at home for people. And these are potentially commercialized products. So alongside our psychotherapy, we also address behaviors of concern or change behaviors in people with dementia. And with the behavior research that's predominantly conducted at residential aged care facilities, where we have trial various virtual and fully immersive virtual environment as particularly lifestyle factors, or as well as to look at reductions in anxiety, depression, apathy in those living in residential aged care facilities. And we conducted trials looking at how these techniques would reduce behaviors individually when the fully immersive experiences are given at an individual basis as well as in group basis. Sorry. Another large portfolio is not just looking at individual improvements in some of these symptomatology that we target and quality of life. We also look at, we have a large program looking at how we can improve mental health care practices in residential aged care facilities, which is the MHI Care Project. The MHI Care Project looks at various aspects of care practices at an individual level, as well as an organizational perspective. And here we are developing a tool to benchmark mental health care practices in aged care facilities. All the projects are funded by various funding bodies, both Category 1 to Category 3. And I must say that within our aging, neurodegeneration, and mental health themes, we have ECR leadership, such as Julia here, and Deborah Brooks here, Eamon Ailes, who drives the Delirium Project. Julia drives our neuroimaging portfolio. Deborah Brooks drives our implementation science portfolio. Peter Worthy drives our technology portfolio within aging and neurodegeneration and mental health research programs, developing their ECR leadership alongside conducting and coordinating research projects. So today I'm going to focus on the TRIP trial, which stands for Therapy to Reduce the Risk of Dementia in Parkinson's Disease. I'll start with a little story, how this the TRIPS trial evolved to give a perspective, especially for ECR, in terms of how some of these trials actually start and how they evolve. So in terms of the TRIP study, it actually started with a trip to USA, where I was once invited to take part in an international consortium focused on neuropsychiatry in Parkinson's disease. After the consortium work, it's really important to emphasize that taking part in social events and having drinks with the colleagues is so important, and that's where we started talking about this project. After a couple of drinks and talking with a number of prominent experts in neurology and psychiatry, Professor Sultan Murray, who is a professor in neurology at Johns Hopkins, as well as Cleveland Clinic Brain Health Center, and associate professor Greg Ponton, who is the director of neuropsychiatry in Johns Hopkins University. The three of us started talking about setting up a consortium, specifically focused on cognitive impairment in Parkinson's disease, in particularly with a special emphasis on neuroimaging. After our discussions, and a year later, with inviting a world-famous neuroimaging expert in dementia, who is here, Associate Professor Arnold Baker. This is where we established our consortium focused on MRI studies in cognitive impairment in Parkinson's disease. We established the consortium and held our first inaugural symposium. And alongside, we established this drug trial to study the levetiracetam in Parkinson's disease. And Brisbane became the leading center to do the proof of concept trial within the consortium. So to do it, I'd like to emphasize 4 key people. Julia, who's our early career researcher, who is coordinating this project. Donna Pourzinal, PhD student, who will speak to you today later. And she's done an enormous amount of work setting up this project. And of course, Tiffany, and my mentor and our study physician, Professor Gerard Byrne. With these people, as well as I'd like to acknowledge the Royal Brisbane Hospital Foundation, who provided us with seed funding to establish this project. And all our projects are advised by our consumer and community involvement group. So we gathered a large number of collaborators from various disciplines to conduct this trial in Brisbane at UQCCR, and a number of partners to drive this project that's looking at a repurposed drug to reduce the risk of dementia and Parkinson's disease. So there's large collaborations in there. I'll start with introducing what this project is about by providing you with this code that was given by one of our consumer and community involvement group members who is living with young onset Parkinson's disease. It shows how important it is for people living with living with Parkinson's disease. Dementia, it scares me. I can cope with physical changes, challenges, and limitations. But what if my intellect evaporates? That really concerns me, and I do not currently have any way to know or measure my likely pathway. Any improvement in early indication of dementia is vital to the well-being of all concerned. So what is Parkinson's disease? Parkinson's disease is predominantly known as a movement disorder because of the visible motor symptoms like tremors, rigidity, problems with walking, and postural instability. However, there are a large number of non-motor symptoms exist within Parkinson's disease. And a large survey recently conducted in the USA demonstrated that cognitive impairment is the most important concern in people with Parkinson's disease. It's a second has a neurodegenerative condition after dementia, but people with Parkinson's at advanced stages develop dementia. In fact, a Sydney follow-up study demonstrated that over 80% of people living with Parkinson's disease developed dementia at advanced stages of the disease. There is no cure for Parkinson's disease, therefore the neurodegenerative continues as the disease progresses. So usually someone with Parkinson's receives a diagnosis as a result of their movement symptoms, but even at the time of their diagnosis, there are subtle cognitive impairments are present in about a quarter of these people. Sorry. Prior to development of dementia, There's another diagnosis called mild cognitive impairment, which is a prodromal stage of dementia. So focus of our work is predominantly on mild cognitive impairment, looking at very early stages of cognitive impairment that puts people at risk of developing dementia and targeting ways to reduce this risk. And the prevalence of mild cognitive impairment in a cross-sectional study reported about 30%. So what's the current treatment methods? For mild cognitive impairment, there's none. For dementia, FDA approved rivastigmine, which is used for dementia in Parkinson's disease. A lot of the trials that's tested for mild cognitive impairment have failed, mainly because there are many reasons for failing drug trials. But I guess one of the main reasons is that if you look at the presentation of cognitive impairment in Parkinson's disease, in particularly mild cognitive impairment, it's highly heterogeneous. It's not just memory impairment. We're looking at attentional impairment, language impairments, executive functioning impairment, and visuospatial impairment. So we're trying to treat a cocktail of various conditions here by using one drug or one intervention. But what's really important is that we need to think about the disease in a different way. Think about what are the subtypes, as there are subtypes, and think about treating or targeting interventions to subtypes or more targeted therapeutic approaches. So in this case, we're targeting memory impairment in Parkinson's disease. So before we do that, we did a systematic review driven by Dana Pourzinal, looking at what are those cognitive subtypes published in Parkinson's disease. And obviously severity-based subtypes were there, but what's really important was there was a subtype of amnestic or memory impairment subtype as opposed to other subtypes. And memory versus executive dominant subtypes, which corresponds to frontal and postural impairments in the brain, and it's based on the dual syndrome hypothesis. So we established that memory impairment is a predominant subtype in Parkinson's disease. So in terms of a targeted therapeutic approach, it's what comes from Johns Hopkins University group led by Michaela Gallagher and by Arnold Becker, who did a series of experiments to first establish the role of hippocampal subtypes, subfields in episodic memory impairment in prodrome to Alzheimer's disease. And the trial, the levetiracetam drug, which is an anti-epileptic drug, repurposing it to memory impairment in prodrome to Alzheimer's disease, but not in Parkinson's disease. So episodic memory impairment is one of the impairments that are particularly seen within the space of memory impairment, early memory impairment in Alzheimer's disease, which is also seen in Parkinson's disease. Episodic memory stands for, there's two branches to it. One is pattern separation and the other is pattern completion. In this case, we're looking at pattern separation ability. So, to tax this, the Hopkins group developed this particular task where in a computer screen, pictures appear and people are asked to identify whether the picture that appears in a computer screen is a new picture, which means they hasn't appeared before. Is it an old one, meaning it's appeared before, or is it something similar, as you can see here, the similar items or the lure items? So this task is sensitive to activation in a particular sub-region of the hippocampus, which is the DGCA3 region here depicted in blue. What's interesting is people with early memory impairment, prodrome to Alzheimer's disease, this part in the brain is highly activated. So this hyperactivity is an important and established marker within the space of early memory impairment prodrome to Alzheimer's disease. Hasn't been established in Parkinson's, that's it, and that's one of the focuses of our study. And what they suggested was levetiracetam at very low doses. It reduces this hyperactivity and normalizes this hyperactivity into control stages, in particular when they're responding to lower trials or the similar trials. So what is interesting is this large body of work within this space, and there's currently a phase 3 clinical trial running to look at the use of levetiracetam in early memory impairment prodrome to Alzheimer's disease. And what our target here in Parkinson's disease is to see whether we see similar effects in this particular subgroup of people who have memory impairment, and to check whether the levetiracetam can reduce the hyperactivity and reduce the risk of dementia at the later stages. So in Parkinson's disease, there's really no functional task that was conducted within the scanner to tax this hyperactivity in the hippocampus. And in our trial, we designed a 2-part trial, which first examines the hippocampal subfield hyperactivity using this pattern separation task inside the scanner to establish the marker in Parkinson's disease. And then to do a double-blind placebo-controlled randomized controlled trial as a proof of concept to check whether levetiracetam treatment will reduce this hyperactivity. So we developed a cognitive test battery based on clinical current guidelines, and what was used in the Hopkins large phase 3 clinical trial. And we came up with the algorithm to identify early memory impairment in Parkinson's disease, in particular for this trial and for publication as well. All neuropsychology tests are conducted at UQCCR, and the task, which is neuroimaging, is conducted at HERV. So we have a large number of achievements within the trip at the moment, and particularly with the publications, conference presentation, and the trial is currently ongoing and recruiting participants into the trial. Because we're looking at a very small subtype of people, obviously the trial can take a little bit longer to complete, but this is the first proof of concept trial examining levetiracetam in Parkinson's disease in terms of memory impairment. So I will conclude my talk by providing this quote by another member of our consumer and community involvement group. My wife's now completed journey with Parkinson's disease included many neuropsychiatric symptoms, including dementia at later stage. We were reactive in our approach and unable to be proactive as impairments were not detected earlier. As a result, the cognitive symptoms seriously impacted quality of life for both of us. This project holds the promise of early detection of cognitive impairment, which would be a game changer. It would also allow a proactive approach to manage cognitive impairment, a profound contribution to improve the quality of life of many people living with Parkinson's disease, their families and carers. So thank you for all the quotes. And you can see how important it is. This research program is for people living with Parkinson's disease and their families and the broader community. So there's a large number of people who are involved with the particular studies I presented today, and a large number of students who have graduated conducting research within our group. So I'd like to thank everyone, and in particular our consumer and community involvement group and all the research participants, and acknowledge all the funding bodies and partners of our projects. And thank you for your attention.
Applause, insert applause. Well done, Nadeeka. That was very, very interesting. I wonder if I could ask people if they have any questions about the presentation from Nadeeka. While we're waiting, I might just ask a question about levetiracetam dosing that's used. What is the evidence behind which dose you choose? Certainly in epilepsy, people can be on anything from 250 milligram 12 hourly up to even 4 grams a day, which exceeds the product information dosing, but certainly is something that's used. How do you choose what dose you should use? And then how do you know that that is the best dose?
Yeah, so in epilepsy, you're right, it's used in very high doses. So the group by Johns Hopkins, they actually did a dose titration, number of experiments looking at what's the most appropriate dose for this particular indication of memory impairment. In their studies, they actually showed that high dose doesn't actually work. It has to be low dose, and within low dose, it should be this particular dosage that they chose by looking at various experimenting different dosages at low dose. If it's too low, it doesn't work. If it's too high, it doesn't work either. So that's why they optimized the dosage to come up with the 250 milligrams per day dose that we use.
Great, thank you. And do you adjust that based on patients' renal function and other characteristics? Obviously, some patients are very young, but will have a much higher baseline renal function than maybe an older person.
So our target population is more older people, and we don't do dose adjustments. This is the proof of concept trial. So we basically use the dose that's used in the phase 3 trial. So there's no pharmacokinetics that we do with this particular trial. It's probably something you could think of.
Cool.
But we do measures of their renal functioning and all that before they go into the study.
Great. Thanks, Nadeeka. I can't see anyone with any other questions, so I might thank you for your presentation, and then we might invite Dana to present next. It's very nice to have Dana online. Dana has already received quite a nice introduction during Nadeeka's presentation, and so many of you will have a really nice feeling for the really strong contribution she's made to the overall program of research which Nadeeka presented. Dana's in her final stages of her PhD in Nadeeka's group, and she very much focuses on cognitive symptoms of Parkinson's disease and trying to understand why certain people progress to dementia in a shorter time frame than maybe others. So it'd be very interesting to hear what Dana's going to present on her using latent class mixture modeling to explore cognitive subtypes in Parkinson's disease. So congratulations, Dana, on reaching so far into your PhD, and we can't wait to hear what you've learned.
Thanks. Yeah, not long now. I'm just going to check everyone can see my screen. Yeah.
Yes, thank you.
Okay, awesome. So yes, thanks for introducing me, Jason. My name's Dana. I'm Nadeeka's PhD student, as she mentioned in her talk. Today, I'll be talking about profiling dementia risk in Parkinson's disease, which Nadeeka gave a lovely introduction to cognitive research in the field of Parkinson's. And I'm just going to hone in a bit further and talk about cognitive subtyping in Parkinson's disease, which is essentially just stratifying groups of patients that have similar cognitive symptoms and prognoses. And you might think, well, what's the point of that? The point of that is actually to be able to identify people with Parkinson's that have higher risk of developing imminent dementia. We have found in the literature and in our own research that people with Parkinson's disease seem to progress towards dementia at different rates. If we can identify those that have the highest risk, that will allow us to target our therapies and interventions to the right people, just to maximize efficiency of our trials. And also there's the flow-on effect of person-centered care and personalized care. For example, people with executive type dysfunctions might have different needs to people with memory or language-based dysfunction. So that's the point of cognitive subtyping. What we found in our systematic review that Nadeeka touched on is essentially there's many different ways to approach cognitive subtyping in Parkinson's disease. In the review, we found subtypes based on anatomy, subtypes based on cognitive domains, that amnestic, non-amnestic split that Nadeeka mentioned, and also subtypes based on severity of impairment. But one particular study that I found very interesting was this study by Anderson and colleagues who used latent class mixed effects modeling to identify subtypes in a large sample of people with Parkinson's disease. Now I'm going to get into a bit more detail about what the actual technique is, but for now, latent class mixed modeling is essentially a way to group patients that have similar trajectories on a specific outcome measure. In this case, for this study, Anderson and colleagues used PPMI data, and I'm not sure if many of you are familiar with the PPMI study. It's a very large international study of, I think, about 700 people with Parkinson's disease that they've been following annually for potentially 12 years and counting. I think they just renewed the whole study. So massive data set with lots of different variables, but essentially these guys looked at the neuropsych variables that were available, which is, I think, 5 neuropsych measures that they distributed among 3 cognitive domains, the executive, memory, and visuospatial domains. And what they did, how they kind of synthesized the data, is that they came up with composite scores. So, for example, in the executive domain, they averaged the Z-scores from the letter number sequencing task and the category fluency task to come up with a composite score that they then entered into the latent class mixed effects model, which spat out 2 different subtypes. So they found one subtype of people with rapid cognitive decline who started with generally low global cognition and then declined rapidly over time. And this was about 10% of the sample, so very small proportion. And then the other subtype was the cognitively stable subtype who performed relatively well and remained cognitively stable over time. And this formed the majority of the sample at 90%. And then, of course, they compared the groups on a whole bunch of different biomarkers and other clinical variables. But while I love the study, and I think it's awesome, I did have a bit of an issue with the fact that they seem to use composite scores for their cognitive analysis. So as I mentioned, the executive domain, they averaged over letter number sequencing and category fluency tasks, but some would argue that these tasks measure very different things and probably shouldn't be averaged across. And the other thing that kind of hinders the interpretation of the results is that you can't really compare the 2 groups on specific cognitive measures. So while we know that the decliners performed quite poorly in these domains and the cognitively stable performed quite well, we don't really know if there was specific impairments that each group had because of the use of composite scores. The other kind of limitation of the study is perhaps that the use of the neuropsych test battery as the outcome variable kind of lacks a bit of clinical relevance. So in terms of like what actually happens in the clinic, they don't really have time to all the resources to administer full neuropsych batteries, and instead usually brief assessments of cognitive function are used, like the mock-up. So in our study, which I'll talk about now, we kind of tried to address these limitations and while also looking at the same kind of sample. So as I mentioned, Anderson and colleagues used the PPMI data. We kind of used the same kind of statistical approach, but tweaked a bit for the same data set in the PPMI. And then we apply the same kind of technique to the icicle PD data as a kind of exploratory confirmatory analysis. Just a bit of background as to what the 2 data sets are. So the PPMI is a huge international data set of people with Parkinson's disease that have been newly diagnosed, so within 2 years of diagnosis, and they are drug naive at enrollment. And data is available from baseline to year 7 at annual increments. The icicle PD data, which was provided by our collaborators on this project from Newcastle University and Cambridge University, is a UK data set that comprises newly diagnosed people with Parkinson's disease with no significant memory impairment, and data was available and is available from baseline to year 4.5 in 18 monthly increments. In terms of the cognitive data that was available from both data sets, I've just roughly grouped them into cognitive domains here, but feel free to ignore that. Essentially, the PPMI data set had measures of episodic verbal memory, like the Hopkins Verbal Learning Test. They had category fluency, judgment of line orientation, which is a visuospatial measure. And for executive and attentional processes, they had the symbol digit modalities test and letter number sequencing. In terms of the ISCORE-PD study, theirs was a little bit different because they used the CANTAB battery. So the PAL, PRM, and SRM are all part of the CANTAB neuropsych test battery, and they all are kind of measures of forms of memory measures. They also had category fluency, which is the only mutual cognitive measure across the two data sets. And for executive functioning, they used one-touch stockings test of Cambridge and pentagon copying. And then for the attentional type measures, they had 2 reaction time measures from the cognitive drug research battery. So that's kind of what we were working with in terms of cognitive measures. In terms of sample characteristics, the 2 samples also differed pretty greatly. So with the PPMI data set, we had around 560 people with Parkinson's, whose data we could use for this particular study. ISCORE-PD had around 200, so some pretty big data sets. The PPMI sample was generally younger, well, significantly different on these facts as well. Generally younger, more educated, had lower motor symptom severity as indicated by the UPDRS-3 score, and also scored slightly higher on depression as demonstrated by the geriatric depression scale. There was also a difference in disease duration. I might note here that PPMI had that 2-year exclusionary criteria, whereas the ISCORE-PD was actually an incidence of cognitive impairment study. So pretty much as soon as the person was diagnosed, they were enrolled in the study. So that explains that difference, but it's not too grand. It's I think about a year versus 5 or 6 months. So in terms of what we kind of actually did to the data, latent class mixed effects modeling, which I briefly explained before, is just a way to stratify heterogeneity in the data. So it's a person-centered statistical approach that essentially groups data that show similar patterns over time. Now, this isn't any actual data here on the right. I've just kind of tried to highlight how the method kind of picks out people with similar trajectories on the given outcome variable and puts them into groups, which are called latent classes. And so for this specific technique, you can have one or you can have multiple outcomes. Anderson and colleagues decided to have those 3 cognitive domain, cognitive composite scores. For the present study, we actually chose to just look at MOCA as the sole outcome for the reason that it is more clinically relevant, and we wanted to just kind of get a picture of the patients as they would present in the clinic over time. The MOCA turned out to be non-Gaussian data, which is not surprising. It was not a normal bell-shaped curve, so we did have to explore different types of transformations. And we also did explore the 2, 3, and 4 class structures. So essentially with the technique, you give it the number of classes that you want it to spit out, and then you compare each of the models on what we chose to compare them on, at least, was the Bayesian inference criterion. So the one with the lowest BIC was determined to be the best fit to the data. We also took an exploratory confirmatory approach with the PPMI dataset being used to explore the number of classes that's optimal for the data, and the ISCORE-PD dataset to essentially confirm the class structure. So in terms of results, this is what we found in the PPMI dataset, these 4 classes. These first 2 up here, class 1 and 2, they were cognitively intact groups. As you can see, they were pretty cognitively intact from the get-go and remained cognitively stable throughout. They were the lowest in terms of, they had the lowest age in terms of the entire sample and had low disease duration at about the 1-year mark. The best performing class in terms of cognition, they had also the lowest motor score, and both groups had generally high education, around 14, 15 years. Class 3 was the globally impaired class. So they had a generally low MOCA score from baseline and throughout. They had an average age and generally longer disease duration at around 3 years. They had a higher motor score and depression, which is unsurprising given the link between motor symptomology and depression and cognitive impairment in Parkinson's, and the lowest education at 12 years. Given that they had such a low MOCA score at baseline, it raises the question that potentially is this a dementia with Lewy bodies group that kind of just snuck under the radar. Class 4 had the greatest decline in cognition. They started pretty high in terms of their score on the mocker, but then declined rapidly. They were the oldest, had longer disease duration, at least compared to the cognitively intact groups. But interestingly, they had low motor score, which again, it just surprised me a bit, given that high motor score is quite often related to cognitive impairment in Parkinson's, and a pretty average education at about 14 years. In terms of the cognitive profile, so this is a heat map demonstrating the cognitive performance of each of the classes here. On the bottom, we have each cognitive variable, and the darker shades reflect greater cognitive impairment, so poorer scores, and the lighter shades reflect better cognitive function on each of the tests. So as we can see, class 1 and 2, these are the cognitively intact classes. They performed quite well across all the measures. Class 3 was the potential DLB group, which performed the worst across the board. And then class 4, which is the group that had the rapid cognitive decline, showed an interesting pattern where they were generally okay across most of the measures, except for the judgment of line orientation, which they seem to show a slight deficit in. And in terms of statistical significance, which I haven't included here for brevity, this judgment of line orientation was the only measure that they really scored differently to the cognitively intact variables on. So it showed some sort of tangible deficit, which is interesting, suggesting maybe judgment of line orientation can be predictive of rapid cognitive decline in this sample. As for the iSchool PD results, so we found kind of similar results. So these two classes up the top, they can be considered the cognitively intact groups, class 2 and 3 here. They had pretty average age, high education. Again, class 3, the high performing class, they had the lowest motor score. Class 4 is the globally impaired group. Again, the oldest with the highest motor score, lowest education, very similar to the previous potential DLB group. The same questions are raised here. And finally, we have class 1, which is here. They had mild decline, which is very different to the PPMI study. PPMI, we saw quite a rapid decline in that final group, but for this one, the class 1 only really showed mild decline, but they were older and had low education, fitting kind of that profile of the potential cognitively impaired group. Again, looking at the cognitive profiles of each of the classes, we can see class 3, which was the highest performing group, performed pretty well across the board. Class 4, which was the potential DLB group, performed pretty poorly across the board. What is quite interesting is class 2, which was the other cognitively intact group. So this group remained pretty stable over time. They had a generally intact profile, except for perhaps on this measure of attention, which is the simple reaction time measure from the cognitive drug test battery. But other than that, didn't really show much of a deficit. And then class 1, which showed a bit more of a deficit across the board, but the only measure that class 1 kind of performed similarly to class 4 on, the poor performing group, was category fluency. So this was the measure that showed the greatest deficit, which is interesting given that category fluency has come up a lot in the literature in terms of a measure that can predict cognitive decline in Parkinson's disease. So what can we conclude? Essentially from the PPMI stuff, judgment of line orientation seems to be somewhat predictive of rapid cognitive decline, but considering the sample characteristics and also the characteristics of that particular subtype within the PPMI sample, perhaps this is only relevant to people with Parkinson's with an average sort of age of onset in early 60s and higher education. On the contrary, in the iSchool PD study, we saw that category fluency might be predictive of mild decline in this sample. Again, considering the sample characteristics, perhaps this is only relevant to people with Parkinson's with older age of onset, starting at kind of early 70s, and lower education at 11 years. And I think it is important to note as well that given that category fluency seems to come up in the literature a lot in Parkinson's disease, but also in general older adult populations as a predictor of cognitive decline, it is important to consider this comorbid Parkinson's, Alzheimer's pathology that can occur in Parkinson's disease. So 30% of people with Parkinson's disease at autopsy also show considerable Alzheimer's disease pathology that's often undiagnosed. And this group seems to have an older age of onset and sometimes lower education. So it's, yeah, just something to consider for future research that I found quite interesting. And maybe category fluency is potentially predictive of this kind of comorbid pathology. But that's going too far for this study. It's just something I want to look into in the future. So strengths of the study, it's data-driven, large sample size, good follow-up length, newly diagnosed people with Parkinson's, which is awesome because we get to, I guess, evaluate people from diagnosis and as they progress through the years. Limitations, attrition, and also selective attrition, which did definitely affect this study. The more impaired participants were more likely to drop out as the study progressed, but this is an issue that is so intrinsic to cognitive research in older adults in terms of longitudinal research, and it can't really be avoided. So I think just being able to discuss the bias that potentially occurred for the more impaired groups is really important. I think that's it, yeah. So thank you to everyone who collaborated on the study and who will continue to collaborate. We're in the process of producing a manuscript, so hopefully that's out before I submit my thesis, but who knows.
That's great, Dana. Thanks so much. Really interesting stuff. Could I ask if anyone has any questions for Dana? Whilst you're all well, good, Nadeeka. This will be a tough one. Good luck, Dana.
Sorry, if there's no other questions. I'm quite interested to hear why you say that the class, the low performance class as a DLB. Have you sort of looked into the criteria for DLB versus PDD? And these are people with idiopathic Parkinson's disease, I believe.
Mm-hmm.
Have you looked into in terms of whether they had cognitive impairment before the appearance of motor symptoms? That's one of the criteria. And the other criteria in terms of sleep. I'm sure Lara here could tell more about this as from a neurological perspective. And the other thing is, because these are newly diagnosed people with Parkinson's, levodopa responsiveness is one of the criteria for the diagnosis of Parkinson's disease as well. So I'm just quite interested to sort of hear why you think that group is potentially a DLB, not Parkinson's disease, or if you could comment on it, please. Sorry, it's probably very hard questions.
No, that's actually so fine, because in the manuscript I debated including a big paragraph about why I thought potentially these guys were dementia with Lewy bodies. And I think what it really comes down to is the criteria seems to be that it's just a matter of timing. So it depends when the cognitive symptoms appear or when the motor symptoms appear, with a 1-year rule, in that if there's no cognitive symptoms for 1 year, then it's Parkinson's, but if there is, then it's DLB. And so the reason why I think it might be DLB is because given that the participants should be newly diagnosed at baseline, which in the PPMI study doesn't really seem to be the case, but at least in the iSchool PD study, the disease duration is quite, short or narrow length of time, that it can be assumed that the cognitive impairments that are experienced by these people happen within months of being diagnosed. And so given the 1-year rule, I would kind of suppose that potentially, given the severity of their cognitive impairment, which does seem to be below the 20-point mark on MOCA, which is indicative of probable dementia, that it might be a possibility. But that's a really good point. I haven't really looked into any of the other kind of clinical factors that go into the diagnosis or any of that kind of stuff, which I don't know if I will, given that the manuscript is already so long, but maybe as a separate study looking into DLB in these samples and how it's diagnosed. But that was a good question. Not too tough.
Thanks.
Dana, I was wondering if you could comment on, certainly in my area, there are some interventions which get applied between different jurisdictions, so different patient case mix, if I could call it that, from one country to another, whereby the results are strikingly different in terms of how successful an intervention is. I was wondering whether or not in your expert knowledge of this area now, that this is something that you've come to observe sometimes as well, as that a report that about an intervention, say, that you've tested versus what another group has, or alternatively where two different groups have tested, that there is quite a significant difference, if I could put it that way, in terms of what the outcome is of that intervention. And it's very difficult to understand what that difference is, because it appears to have been applied to two similar patient populations, but they're just in completely different places. Is that something that you've observed in any of your research, including your literature reviews? And do you have any thoughts about in a neurodegenerative disease world, what might be driving some of those differences?
Yeah, that's a really good question. Well, I think the only interventional study that I've been working on, we still haven't finished it, so that's still in progress. But in terms of what I've seen from other studies, yeah, for sure. I mean, the difference is just sometimes at the different countries where the protocol might be exactly the same. But I think when it comes down to it, I guess this differences may also exist, not across countries, but from site to site, and it all boils down to how the research staff are conducting their research. And I actually noticed this with one of the longitudinal studies that I've been working on, where the kind of raters from the MOCA were different from pre and post, and how that may have affected the scores, and the need for inter-rater reliability type measures in order to be able to be confident in your scores that you are collecting. So even just something as little as having different, people conducting the study can affect the outcomes. But there are ways to, I guess, minimize the impact that has.
Cool. Thanks very much for that. Well, there doesn't appear to be any more questions. We're just coming up to 1 o'clock, so I might conclude the seminar there, and thank both Dana and Nadeeka for really interesting presentations, which I hope that you all learned something from. And hope you all have a wonderful afternoon, and I look forward to talking to you again at the next edition of the seminar series. Okay, bye.